على السبيكرز اللي بحب يشارك يرفع ايده من دخله. اهلا دكتور فادي.
يعطيك العافية دكتور، شكرا كثير لك ولوقتك ولجهدك، يعني مقدرين هذا الشيء كثير وتحترم عن جد على الجد النزول، وجميع الأعضاء المشاركين بالروم. أنا ما بعرف بالضبط شو اللي رح يكون على الروم، دخلت متأخر شوي، بس كان عندي كم سؤال بالنسبة لامبارح كنا بروم سوا، وفي عندي كمان لسه سؤالين، فإذا بتسمح لي أسألهم هلا أو فيني أنطر كمان حتى تخلص موضوع الروم فينا نرجع نتناقش فيه.
بص يا فادي، بعد إذنك، هو النهاردة مش أسئلة، هتبقى الروم هي عبارة عن فيرتشوال كلينيكال راوند. يعني كأننا في راوند بطنة، الدكتور هيقدم لنا حالة، هيقول السيمبتومز واحنا هناخد الهيستوري، ويعني والدكتور بقى هيناقشنا كأننا موجودين في راوند في المستشفى، بناخد هيستوري من عيان وبنمشي بالإجراءات يعني زي ما الدكتور هيوجهنا. فالحابب يشارك في الراوند يرفع ايده وهندخله تمام، والدكتور هيحاورنا. والأسئلة احنا بنعمل رومز تانية إن شاء الله تبقى مخصصة للأسئلة.
أوكي.
فهذه إن شاء الله يعني زي ما حكى دكتور محمود نعمل رومز تانية للأسئلة، بس خلينا نحاول نخلي الروم هاي لنفس الموضوع حاليا. أي حدا تاني بيحب يشارك بالكلينيكال راوندز يرفع إيده من دخله إن شاء الله. أهلا رشيد.
أهلا.
تعرف عن حالك؟
رشيد عبد الله الشريف من ليبيا. طبعا أنا في آخر سنوات الانترنشيب وعم بحضر للسيكي.
تمام ممتاز. طب رشيد نبدأ معك. خلينا نعتبر إنه أنا مريض وحكى معك طبيب الطوارئ في المستشفى، أنت first year resident بالinternal medicine service، وقال لك هذا المريض اجى على المستشفى عنده shortness of breath والاكسجين saturation تبعه كان 88 في الطوارئ، وحطوه على 4 liters of oxygen. هلا الاكسجين saturation تبعه 92%، و they got a chest x-ray، وبحكي لك طبيب الطوارئ انه it looks wet. فهلا انت بدك تيجي تاخذ مني انا المريض history، وبعدين we will discuss الكيس together. مبدئيا انا راح احاول بقدر الامكان انه نخلي كل conversation والدiscussion وكل شيء بالانجليزي as much as we can، على اساس انه تتعودوا على اللغه الانجليزيه، تتعودوا على الاكسبريشن باللغه الانجليزيه، على الهيستوري تيكينج والدiscussion والبرزنتيشن. فدكتور رشيد تفضل. دكتور رشيد معنا؟
حاليا انا بالهوسبيتال. اوكي، مش عارف
اوكي
بقدر اشارك او لا، بس
بسيطه مش مشكله.
اوكي، انا على بالي كان ديسكشن او هيك، مش عارف، لكن تمام.
طب يا دكتور انا ممكن يعني يعني هو ممكن بس الحالة ايه، يعني هو الطلب مني ايه بس؟
هلا انت هلا internal medicine resident first year، رن عليك طبيب الطوارئ بالمستشفى to admit a patient، وطبيب الطوارئ حكى لك patient came in with shortness of breath, with an oxygen saturation of 88%, and they put him on 4 liters of oxygen. His oxygen saturation went up to 92%. They got an x-ray and they told you the x-ray looks wet. And basically now you're going to go to the emergency department, you're going to take history from the patient, and we'll discuss later the admission orders, what you want to do and how you want to proceed. Does that sound good?
تمام. طيب انا اول حاجه يعني هسال عن نيم، what's your name، ولا هبدا بقى من الاول خالص يعني نيم والايدج والكلام ده، ولا امشي ازاي؟
اتفضل اعملها يعني as تخيل انك انت هلا في المستشفى، do it exactly the way you would do it.
Okay. Hello sir, how are you? What's your name?
My name is Bara.
how are you today?
I'm feeling a little short of breath. My chest is a little tight, and I'm having trouble breathing.
When did this start, the shortness of breath?
It started last night. I thought that it would go away. I tried to sleep it off. It was a little bit difficult to sleep. When I was lying down, I was having trouble sleeping. I had to get up and sleep on my recliner.
Yeah, anything that make you more comfortable? You say standing, like sleeping on more than one pillow, you said?
Well, last night I only have one pillow on the bed, so I didn't try, but I felt better when I slept on my recliner.
Okay, and what increase the shortness of breath? Make the symptoms worse.
Well, any type of activity, if I walk, if I exert myself in any way, I feel the shortness of breath getting a lot worse. And basically that's it. I haven't tried anything else, but when I lied down in the bed, I also felt like it was worse.
Did you have any attack like this before, or this is the first time?
Well, this is the worst that it's ever been. I've noticed in the past few months that I've been getting short of breath when I exert myself and when I walk around the house, when I do some yard work. I've noticed that I'm getting less tolerant to this type of work. But I've never experienced anything this bad before.
Okay, after you do some activity, you feel these symptoms, right?
Yeah. After activity, but yes, since last night, it's just been there. Even if I'm sitting and doing nothing, I'm still feeling short of breath.
So you now feel these symptoms in rest, but before you feel the symptoms when you do some activities.
Yeah, and even now, if I exert myself, the symptoms get a lot worse.
اوكي. هو احنا كده يا دكتور خدنا الهيستوري اوف بريزنت illness. احنا ممكن نكمل في اي حاجه، يعني انا سالت على ايه الحاجات اللي هي بتديكريز السيمبتومز، ايه الحاجات اللي هي ممكن بتقللها او بتزودها. تمام. وسالنا على السيمبتومز ابتدت من امتى، فهو قال من لاست نايت. تمام. وسالنا على اذر يعني اتاكس جت بيفور. في حاجه تانية ممكن نزودها على البريزنت هيستوري؟
هلا انت برضو بدك تعرف يعني what could predispose the patient to these types of symptoms, and you also want to rule out other differential diagnoses, all that kind of stuff. So I mean, the history is good for description of the symptoms, but you still haven't touched on the questions that will give you the diagnosis or will rule out other diagnoses. فهلا يعني I'm short of breath. You want to know what could cause shortness of breath. So there are a lot of etiologies that can cause shortness of breath. You have to ask about these. So you have to consider, for example, pneumonia. So you have to ask questions to rule out pneumonia. You have to consider pulmonary embolism, for example. So you have to ask questions to rule that out. You have to consider acute coronary syndrome, and you have to ask questions to rule that out. And you have to consider heart failure, and you have to ask the questions to rule that out. So basically, your history as a description of the symptoms was very good, but the other part of the history is to explore the other differentials and rule them in or out.
تمام. يعني في البريزنت إلنس برضو بنحاول نسأل على الحاجات بتاعة الديفرنشال، سواء الحاجات اللي هي ممكن عشان أعرف الكوز، يعني عشان أحاول أوصل للكوز. تمام.
أيوة بالظبط.
خلاص اوكي.
لأنه
طيب
أنت هلا بعد ما تاخد الهيستوري, after you take the history, you're gonna go and you're gonna start ordering labs and imaging studies and procedures and all that kind of stuff. So you have to have an idea how to best utilize the resources you have available. فبدك تعرف إيش تطلب, and you will decide that based on the history, because instead of having, say, a list of 10 differential diagnoses, after you take a good history, that should be narrowed down to maybe 2 or 3 diagnoses.
تمام. طيب okay, do you have any fever?
I haven't felt hot at all. I haven't tested measured my temperature, but I've not felt like I had a fever.
Do you have any like common cold or cough, sneezing?
I've been having a kind of dry cough, but this has just started yesterday with the symptoms, but no sneezing or kind of leaking through my nose or anything like that.
Okay. Do you feel like you have a rapid breathing more than usual? Your breathing more frequent?
Not really, no.
Okay. Do you feel like you gained weight in the last few days or last few weeks?
I haven't really measured my weight. I haven't gotten on a scale, but I feel puffy. I feel like I'm getting puffy. I feel like my legs are getting a little puffy.
So you feel like your legs are like swelling? You have
They
swelling
look
in your
full.
legs?
They look full. I'm looking at my ankles and they look full.
Okay. Do you feel any like change in heart? You feel like palpitations or a change in your heart rate or something like this?
No.
Do you feel any chest pain or tightness?
No chest pain. I feel a little tight. My chest feels a little tight, but I don't have pain.
Okay. Did you have any right or left shoulder pain?
No shoulder pain. No.
Okay. Did you feel any warmness in your calf, in your leg, your calf muscle?
No.
اوكي. طيب يا دكتور، انا كده سألت على التمبريتشر عشان اشوف لو هو كان او اي كومن كولد او اي حاجه، فعشان اشوف لو هو كانت عنده اعراض نمونيا مثلا. سألت على الريسبيراتوري ريت لو هو عنده تاكيبنيا، او سألت على عشان اشوف برضو لو في بالمونري امبوليزم برضو عشان لو هو عنده دي في تي مثلا فيبقى في سويلنج في الليج او اي حاجه من الحاجات دي. بس برضو هو طب الهارت البالبيتيشن عشان لو شوف سوري الشيست تايتنس او الشولدر بين، عشان لو هو عنده حاول اشوف اي typical angina pain، فهو ممكن يكون عنده atypical angina pain ما دام الشيست تايتنس بس. بس الهارت فيلير، طب احنا مش عارف بقى حضرتك تعملي جايدنس كده.
طيب جميل. هلا خلينا نحاول anybody بالاودينس عنده other questions that they feel like are pertinent and need to be asked. If anybody is in the audience has any additional questions, please raise your hand.
انا حابب بس اشجع الناس ان هي تدخل وتشارك يا جماعه. يعني احنا بنعمل الكلام ده عشان نشيل الحرج، حتى لو انت طالب او لسه احنا نتعلم مع بعض، فما تتكسفوش يعني ان انتوا تشاركوا.
تمام.
Okay, hi sir. I have a question. How old are you?
دكتور فادي تفضل.
How old are you?
How old? Yeah, I'm 63.
63. Do you smell good?
I'm sorry?
Can you smell good? Sorry. Can you smell good? Can you taste and smell good?
Oh, I have taste and smell. I don't have I don't have any trouble tasting or smelling anything.
Okay. بسأل سؤال بس بسبب انه كوفيد، يعني بسبب انه نحن حاليا بالكوفيد سيشن يعني.
Just one point. The way you phrased that question was nobody here will understand it, and some people will get offended. If you ask someone, "Do you smell good?" that means that they might smell.
Okay, ask it.
لا بسيطة، أنا بس بحكي قاعد to avoid these things in the future لما تعمل مثلا if you haven't done your CS exam, also in the future بالمستشفى try to learn the right way always of asking the questions. So it's good this is why we have these rooms, so you can learn so you can make the mistakes here that and avoid making those mistakes later on in the future. The way to ask this question is, have you lost your sense of smell and taste? My answer would be no, I haven't. تفضل دكتور فادي إذا عندك other questions.
اوكي، شكرا للتصحيح.
ولا
اوكي، بحاول اعمل يعني فريز. انا اسف يعني بالموضوع اللغه شوي نسيان انجليزيه.
No, that's good. That's good.
رح احاول قدر الامكان. Have you ever
again,
had...
this is why we do this, عشان so that you can get better at it. So go for it.
Have you had in the last time operations?
Have I had any surgeries? No surgeries. No.
No surgeries. Do you hear your heartbeat when you sit down?
When I sit down, what was the question?
Do you hear your heartbeat?
No, I can't feel my heart beating. No.
Okay. Have you ever had other pulmonary events or cardiac events?
I had told me I had a minor heart attack about 10 years ago, and they put me on a bunch of medications, and but I haven't had any problems since then.
Okay, what kind of medication do you take?
Well, I'm taking baby aspirin. I'm taking a couple of blood pressure medications. I don't remember them. One of them is a little green pill, and the other is a little white pill with a number on it. And then I'm also taking a cholesterol medication. And I'm taking another blood thinner. I don't know what it's called. I don't remember. It starts with a P, I think. But that's it.
Okay. Do you have in your family some sorry. Do you hear me?
Yeah, I can hear you.
Okay. Do you have in your family some syndromes or some common syndromes?
Well, I mean, I don't know what you mean by syndrome. My father had diabetes, and my mother has hypertension, or had hypertension. I have a brother who has heart disease, and I have another brother who is currently struggling with colon cancer. But I don't know what you mean by syndrome.
اوكي. نكمل سؤال.
فادي صوتك شوي بقطع. طيب فادي did very well. سأل شوية أسئلة يعني هي in medical school sometimes they teach you to start with the history of presenting illness and then do the past medical history, but sometimes past medical history is extremely important and should be part of the history of presenting illness. So in a case like this, it's important to ask, what does the patient have history of? So it would be very pertinent to know if the patient has, for example, an immunodeficiency that would make them more susceptible for pneumonias, or if the patient has difficulty swallowing that would make them susceptible to aspiration pneumonia, or if the patient has, for example, history of heart disease that could precipitate them either to acute coronary syndrome or to congestive heart failure. It would also be important to ask about past history, for example, of blood clots. So you know if the patient has a susceptibility to form PEs. So it's very important to ask also about history of diabetes, history of hypertension, history of chronic kidney disease. All of these can predispose patients to get heart disease as well as heart failure. So these are past medical history questions that should be part of your HPI. And usually when I approach patients like this, these are the first questions that I ask, because it kind of gives you a better picture before you start asking about symptoms. It will narrow things down, and it will increase your acuity, the accuracy of your history. طيب any other questions أي حد بفكر فيها؟ تفضل.
دكتور براء، ازي حضرتك؟ انا بس يعني عندي اقتراح، بس
تمام.
هنخلي الموضوع انتراكتيف بعد اذن حضرتك، لو حضرتك يعني توافق عليه. انا رايي ان احنا مثلا يعني ان احنا نمشي بطريقه السي اس، بحيث ان هو يبقى عندنا عناصر الهيستوري مثلا اتش بي اي، باس ميديكال هيستوري، سوشيال هيستوري، هكذا، وحضرتك تمسك كل عنصر فيهم يعني اي حد موجود في السبيكر حضرتك تمشي عليه بالدور. يعني مثلا كل واحد ياخد سؤال واحد، تقول اللي عليه الدور ايه السؤال اللي عليه الدور، دكتور فادي اتفضل، فهو دكتور فادي مثلا يجاوب، بعدين حضرتك تيجي عليا انا ما اعرفش اجاوب مثلا، فاللي بعدي يجاوبني، يعني بحيث ان هو اي حد موجود في السبيكرز الاسئله تدور عليه في كل عنصر من عناصر الهيستوري، واللي مش حابب ان هو يشارك في الاسئله ينزل تحت في الاودينس، بحيث ان الموضوع يبقى انتراكتيف يعني.
تمام، مش مشكله. هلا ما فهمتش عليك بالضبط. يعني هلا احنا مثلا we did the HPI, then somebody now will do the past medical history, and then somebody will do past surgical, and then somebody will do social.
هو تمام، هو طبعا زي ما حضرتك تحب. هو انا كان رايي ان احنا الاتش بي اي نقسمه نفسه على الناس اللي موجوده، بحيث ان كل شويه الناس تجاوب، يعني بدل ما هي تفضل قاعده جدا قاعده، بحيث ان يبقى في انتر اكشن شويه والناس اللي تحت تشجع وتدخل يعني.
تمام، جميل جميل. طيب الدكتور احمد، عندك اسئله؟
وانا ما اعرفش المين كومبلين ايه اللي انا دخلت
لا، انا بقول احمد حبيب.
أنا كنت I want to ask if you have any chest pain.
No chest pain. My chest feels a little tight, but I don't have chest pain.
Okay, hemoptysis. Did you vomiting blood?
No, I didn't. I didn't vomit any blood. Now, the right question is, have you coughed up any blood for hemoptysis?
Yes, cough. Okay.
Yes.
Okay.
نخلي الدكتور محمد برغوث.
هو الحقيقة أنا برضو مش عارف إيه يعني
عيد البرزنتيشن
yeah.
عيد البرزنتيشن بسرعة، لأنه I think we have a lot of other people in. Basically, you're a first-year resident on the internal medicine service. The emergency department doctor calls you and tells you that he has a patient for you to admit. The patient is a 63-year-old guy. Came in with shortness of breath, was found to have an oxygen saturation of 88 in the emergency department. They put him on 4 liters of oxygen. His oxygen saturation is 92 now on 4 liters of oxygen. And they took a chest x-ray, and the chest x-ray, they told you it was wet. So now you have to go see the patient, take a history, do a physical examination. Then you're gonna come back, you're gonna discuss this case with your attending physician. And then you're going to go and basically go in and put in the orders and admit this patient and assume care for him. So في البداية الدكتور محمود والدكتور فادي والدكتور أحمد برغوث asked a few questions. So far we've said إنه I've had shortness of breath that's lasted 1 day. It's worse with exertion, worse with lying down. I felt better when I slept on a recliner. I didn't have chest pain, didn't have fever, and I have history of a minor heart attack that happened about 10 years ago. I'm taking baby aspirin, a couple of blood pressure medication and cholesterol medication, as well as a different blood thinner that I can't remember. And I think basically that sums things up. So Mohamed,
I will start by doing an ECG for him, because it must be the person.
We're doing history for now. So do you have any additional history questions?
I would like to ask about his cardiac history again, but maybe with more details. If you can.
I'm the patient.
Okay. Do you remember what was the problem with the heart?
Well, they told me I had a minor heart attack. I was having chest pain, and they told me I had a minor heart attack.
And did they put a stent in?
They told me that they looked at my heart with some form of catheter or something like that, and there was blockage. I don't remember if they put anything in there.
Do you have the past medical records?
No, I don't have the records with me now.
Okay. Do you have shortness of breath when you at the night when you're sleeping on your back?
Yesterday I noticed that, and I felt better when I got up and slept on my recliner.
Okay. For
Okay,
me,
محمد.
yeah.
Good questions. عم تحاول تعطي detail أكثر عن الايفنت اللي صارت قبل 10 سنين, and it's a very important event. It narrows down the scope of the differential diagnosis for you because it tells you that the patient has history of heart disease. So he more likely has a heart problem than other problems. Good questions. Dr. Ahmed Usama, عندك questions?
Yeah, so I just want to ask a couple of questions regarding the shortness of breath. So how many floors of stairs do you usually climb until you feel short of breath?
Well, I never really had a problem with the flights of stairs, but recently I've been noticing that I can climb only like 1 or 2, and then I have to sit and rest. And definitely for the past couple of days, I can't even get out to the mailbox to pick up my mail. It's been really tough.
Mm-hmm. And when was the first time you noticed that you're getting short of breath so easily?
I think sometime in the past couple of months, I've felt like I've had less energy, and I've been getting short of breath really easy.
Mm-hmm.
And it's been really getting worse. I don't know why. I don't know what's going on. I'm usually very active.
Okay, and do you have any swelling in your lower extremities?
I do feel like they're full.
Mm-hmm.
My ankles are a little full, yeah.
Mm-hmm. And do you experience any pain in your right upper abdomen?
No, I'm not feeling any pain at all.
Mm-hmm. Any nausea, diarrhea?
No, nothing like that.
Mm-hmm. And have you been recently experiencing some abnormal heart rhythms or palpitations, I would say?
No, haven't felt any of that.
Any history of losing consciousness or going black?
No, nothing like that.
Mm-hmm.
Okay, Dr. Ahmed, good. هلا if يعني what were you trying to figure out by asking these questions?
So basically, I was trying to grade the dyspnea, to see like what level of dyspnea is he experiencing, and is this dyspnea actually related to heart failure, right-sided, or it's congestive heart failure? So it would be accompanied with a bilateral lower limb edema, and maybe hepatomegaly, and which sometimes causes pain because of the stretch of the liver capsule.
Okay. Good. Dr. Abdul Sabur, do you have any questions?
Yeah, I was asking about, do you smoke?
I do, yeah, I do.
How much every day?
About a pack a day.
Okay, what about alcohol intake?
No, I haven't had alcohol in a very long time.
No other drugs?
No.
Okay.
No drugs, no.
دكتور، بس أكون بسأل على السؤالين دول تقريبا معظم الشباب سأل معظم الأسئلة اللي كنت هسألها.
أنا مش عارف ولا لأ، بس did we ask about the weight change?
سألوا, yes.
Okay.
I haven't measured my weight. طيب, very good. Let's wrap up the history taking part. I think you guys did very, very well. This is the way I like to approach history taking. I like, first of all, to know as much as I can about the patient's medical history before I start asking about the complaint. So if the patient is medically stable. So you're seeing a patient who's sitting at 92%, in the emergency department, only 4 liters of oxygen. So this patient is fairly stable. So I would ask him about any systemic issues that he has. I would ask him if he has history of diabetes, if he has history of hypertension, if he has any significant past medical history, and basically let them talk about that. Most of the time, patients will volunteer information to you, so that will help you out. And then I become a little bit more specific. So if the patient comes in with shortness of breath, there are certain things that can give you shortness of breath. So you have to ask about those, and you can think about them in any way you like. A lot of people think there are infectious causes, and then there are structural causes, and then there are mechanical causes, and all that. You can stratify the causes in whichever way you like. For me, I like to stratify them based on organ system. So there are cardiac causes for shortness of breath, and there are pulmonary causes for shortness of breath. And there are mechanical causes for shortness of breath. And I would base my questions based on that. So I would start out by ruling out the pulmonary causes of shortness of breath. So I will ask the patient if he has any history of lung disease, because you never know. Maybe the patient has history of pulmonary fibrosis, and pulmonary fibrosis can basically present in the same way. So you want to ask about history of lung disease, and then you want to ask history about pneumonia, for example. Rule out that the patient had any fevers, any cough, and if he had cough, what was it productive or not, and what was it not productive of? What did the sputum look like? And then basically you want to ask if the patient does have pneumonia, you want to ask about previous episodes of pneumonia, and then we can go into a different history in that direction. And then I would, after I ask the questions about the pulmonary system, the pulmonary causes of shortness of breath, I would start asking about the cardiac causes of shortness of breath. And basically, I would start out by asking if the patient has history of heart disease, if the patient had any heart attacks in the past, if the patient has a diagnosis of heart failure, if the patient has ever had an echocardiogram, and if the patient basically is experiencing any symptoms of heart failure, which you all discussed very well, basically orthopnea and paroxysmal nocturnal dyspnea, shortness of dyspnea on exertion, and swelling, lower extremity swelling. Now, Dr. Ahmed Osama asked some questions about right heart failure, which is pretty good. However, just a note, if the patient has an isolated right heart failure, that does not necessarily, that means that they would not have shortness of breath. However, the most common cause of right heart failure is left heart failure. So a lot of the times the patient will have shortness of breath with right heart failure because they also have concomitant left heart failure. Okay, so physical examination wise, خلينا نكمل. احنا وقفنا عند الدكتور محمد ليبرز.
Yes, I'm here.
تفضل
okay.
دكتور محمد.
Okay, so we're starting with the physicals. I just gonna start out by taking the vital signs of the patient.
Okay.
So what's I'd like to know the patient's heart rate.
Okay, so the patient has a heart rate of 88. His blood pressure is 110/63, and his oxygen saturation is at 92. It kind of oscillates between 90 and 94.
That's on room air?
That's on 4 liters of oxygen by nasal can.
Does the patient have any fever?
No fever, no.
Is the patient in like respiratory? What's the heart rate of the patient?
88.
Sorry, the respiratory rate. I'm sorry.
Respiratory rate is 31.
31. Okay. Next on the physical, I would look for. Yeah. Okay. I would auscultate the heart. Or okay. No. Okay. Let me do that. I will check for the pulses first. see if any regular the pulse is regular or not.
Okay.
And then I would go to auscultating the heart and
Auscultation of the heart is normal. Pulse is regular.
Okay. I would go to see if there is any lower limb edema and grade that. So is it on the level of the ankles or on the tibia or on the thighs or
there is pitting edema +1 up to mid leg. Let's go.
Okay.
Yeah.
Mid tibia.
Okay. Okay, so good physical exam. Now, on auscultation of the lungs, you saw bilateral crackles up to the mid chest. So now looking at the labs, the emergency department already ordered CBC and CMP. The CBC basically shows normal values all through. And basically that's the extent of the workup that they did. They ordered the chest x-ray, and when you looked at the chest x-ray, it showed pulmonary edema. And that's what they usually describe as quote unquote wet. Who's gonna volunteer to present the case? I'm gonna basically pretend to be your attending physician, and you're gonna present the case to me. You're gonna give me the history, physical exam finding, and lab findings. And then we're going to get somebody else to tell us what their assessment is and what the plan is. دكتور محمد حسين, I think أنت هلا دخلت والوحيد اللي ما حكى, فحظك.
اوكي. ابدا.
اتفضل.
انا استاذن بس حضرتك دكتور احمد بهواش, بعد اذنك تقفل المايك بتاعك على طول بس.
A 63 years old patient complaining of short of breath. The oxygen saturation was 88 on oxygen of 4 liters. He turned into 92. The X-ray was ordered and it showed a witness, and it's increased with exercise, but now even it present with rest. The attack was present for the last months, but this attack is the worst one. He complained of puffiness of his leg and the past history of minor heart attack 9 years ago. The medication he take aspirin and blood pressure medication and cholesterol lowering medication and blood thinner. He have done catheter procedure and smoking 1 pack a day, no cough, and for clinical examination his heart rate is 88 and no fever. Respiratory rate is 31.
اوكي محمد, انا هوقفك شوي لانه خلينا نحكي على الهيستوري, presenting histories. The way I like to present histories always, انت في البداية you did very well. You described how the patient presented in an acute manner, basically what the ED physician told you, and this is great. This is how I would start. I would start by saying this is a 63-year-old patient. ED called us to admit him because he came in with shortness of breath, oxygen saturation 88, went up to 92 on 4 liters of nasal cannula. And then I would give a little bit of a buildup about basically who this patient is medically. So I want the attending to have an idea about what this patient's medical background is before I start talking about what happened today. So I start by usually this is how I would usually present. I would say this is a 63-year-old guy who has past medical history of coronary artery disease. He had a heart attack about 10 years ago. Basically evidence of coronary artery blockage. The patient also has his family history of diabetes and hypertension, and he presents to the hospital today with shortness of breath and hypoxia. Then I would start talking about the differentials in the way that we presented first. So I would say, for example, the way I like to do it is I start with the most likely differential diagnosis. So in this patient, it's going to be heart failure. So I start talking about heart failure. I start saying that this patient is presenting with shortness of breath. He expresses progressive dyspnea on exertion that started about a couple of months ago and has been progressively getting worse to the point that he now feels at rest. Patient also describes lower extremity edema, and he describes paroxysmal nocturnal dyspnea. Yesterday, he was not able to sleep in his bed and had to sleep on a recliner. And after I talk about the heart failure history, then I would move to talk about the negatives. I like to call them the negatives, and they would basically be the questions that rule out other diagnoses. So I would say, after I told the heart failure history, I'd say the patient denies cough, productive cough. He denies fevers. He denies, for example, any exposure to sick patients or something like that, or denies any upper respiratory symptoms. The patient denies a history of blood clots, say in the past, if you want to rule out PE. And basically, that's the way that I like the HPI to go. And I feel like this will give your attending the best idea about who the patient is at first, and then how the patient presented, and then what other diagnoses you had in mind and you ruled out during your HPI. Now, the physical examination part, Mohamed, there are multiple ways of going about this. Some people like to start out with the positives and then say the negatives. And some people like to go at it systematically, where you start out with the vital signs and then you go system by system and see and say what you found. So I'll give Dr. Mohamed Hussein again the chance to finish the physical examination part.
اوكي. احنا كده خلصنا الهيستوري يعتبر، او يعني حضرتك قلتها بطريقة افضل. هبدأ بقى الاكزامينيشن. تمام. Physical examination show edema of 1 plus and with auscultation bilateral crackles up to mid chest. Lab investigation CBC normal and CMB normal, no special finding. X-ray show bilateral pulmonary edema.
Okay, جميل ممتاز. هلا physical examination, I would always start with the vital signs. Vital signs are the most important thing. لأنه vital signs are going to tell you if this patient needs to go to the ICU or needs to go to the floor. If this patient, you need to go run to the emergency department right now to see him and intubate him, for example. Because if I ask you about the vital signs and you're telling me, for example, that this patient has a blood pressure of 70/30, and he's satting, he has an oxygen saturation on a physical exam that was at 76, and a respiratory rate of 43, then I know that I need to go run to the emergency department right now. But if you give me stable vital signs, the patient has a blood pressure of 113/60, and he has a respiratory rate of 22 and an oxygen saturation of 94. That's a completely different story. So the most important part in the physical examination, always start with the vital signs. And then you're gonna talk about, again, if you start out with the positives, then you have to mention the negatives. So it's important to mention at least pertinent negative stuff in your physical examination. So stuff like a heart murmur and I'm blocking out. I can't think of anything else. But basically, mention the negatives. The best way to do the physical exam, and this is the way that you're going to do it in residency in the future, as well as in the CS exam, is you're going to do it system by system. So you're going to say, start out with the general description of the patient. The patient was sitting up in a bed. He looked like he was in moderate distress. He was, for example, breathing heavily. I was able to see that he was using accessory respiratory muscles. For example, we didn't talk about JVP, but it would be important in this patient to measure the JVP and try to see if the patient has fullness there. And at the same time, you also want to go about this in a systematic way. So you describe the patient generally, and then you go to, you can go about this any way you like. You can describe the head and neck first, and then you can describe the respiratory exam, cardiovascular exam, abdominal exam, genitourinary exam, musculoskeletal exam, neurologic exam, and the last is most likely going to be your skin exam. And I would go about these in a systematic way that you always do on all of your patients all the time in the same way, because you want to memorize this, you want this to become habit, so that you don't miss anything in the future and you don't forget about any pertinent information. Okay. Who wants to give us their assessment and plan?
هو انا كنت عايز بس بقترح، هل ينفع نسال عن النيك فينز مثلا في العيان ده عشان نشوف الجاجلر فينز ديستنشن؟ انا مش عارف النيك فينز والكلابنج في الهاند.
هلا ممكن تسال. He doesn't have clubbing. Neck veins are unremarkable, but you would have to take a look at, you would have to measure the JVP. That would be a different thing. But just looking at them, they're unremarkable.
Okay, thank you so much. So I can start with the assessment plan. Okay, so I'm going to go for investigations. This is best next step, and I think so. Is this correct?
So we're gonna start with an assessment. Assessment is your sum up of what the patient's presentation is and what his differentials are and what is the most likely differential in a nutshell, which means basically I want you to use 2 to 3 sentences to sum this patient up.
Okay, so I think that this patient is having a heart failure due to coronary artery disease, which is the most common cause of, which is the most common secondary cause for heart failure. And the differential diagnosis for this patient will be COPD and COPD or any type of pulmonary diseases, other types of pulmonary diseases, or I don't know either differential diagnosis. So it's just in my mind now only heart failure due to coronary artery disease and COPD.
Okay, good. The way you want to do the assessment is always, again, you want to sum things up in a very short and distinct way. So the way I always do this is after I say the history and the physical examination and the lab findings and all that, I say, so essentially this is a 63-year-old gentleman who presents to the hospital with shortness of breath and hypoxia. Likely secondary to heart failure. However, other diagnoses include COPD, pneumonia, or PE, for example. And that's it. This is your assessment. This is enough. It's basically more than enough because it sums everything up very well. You don't have to explain why you're thinking this in the assessment part. The assessment part is basically just 2 to 3 sentences in which you sum things up. Okay, so that's the assessment. What's your plan?
My plan is to start with transesophageal echocardiogram, transthoracic echocardiography to diagnose the heart failure as the best initial test.
And that's it. That's your plan.
No, that's not my plan. That's the best
Okay.
step to diagnosis. But my plan is to start treating the heart failure if he's having a pulmonary edema, as we said, and he's having dyspnea. So we will give him furosemide for the volume overload. We can get. He is already on oxygen, so we will not give him oxygen again. We can give, if he is having an anxiety, we can give him morphine. And we can give him ACE inhibitors because he's having an acute heart failure. And this is for the initial management. And to diagnose him, we can start with transthoracic echocardiography.
Okay, good. So it's a good plan, and I would always start with the more pressing issues. So, for example, in this guy, we said he has pulmonary edema, like you said. So I would say that the first thing that you want to say is, where do you want to admit this patient? So do I want to admit this patient to the ICU, or do we want to admit them to the floor? Or some hospitals have something in between, an acute care unit or something like that. So you have to decide where this patient goes. To me, this patient can go to the floor. So you say, I want to admit this patient to the medical floor. I want to give them diuresis, because a diuretic, because this is what's going to treat their pulmonary edema. And I still don't know why they have pulmonary edema. There could be multiple different reasons why they could have pulmonary edema, but for now, we're going to treat that pulmonary edema with diuretics. So furosemide is a good diuretic. It's one of the most commonly used. And then you have to decide whether you want to give that in IV form or you want to give it in oral form. And that's something that we can go, over some other day. But basically, you want to treat their pulmonary edema. That's the first thing you want to do, because that's the most pressing issue. Then, you want to get an echocardiogram. That's also a good thing, because you want to diagnose them having heart failure or not. And then you can try to look at what other tests you can do or you need to do. So, for example, in this guy, he's coming in with symptoms of heart failure, but we don't know what caused his heart failure. His heart failure could have been caused by an acute coronary syndrome. So he could have had a heart attack. And as you guys well know, patients who are elderly don't have to present with chest pain when they have a heart attack. So you have to order troponins, right? And you have to get an EKG, right? Because you want to make sure that this patient is not having an acute coronary event right now. And based on that, you can decide, for example, whether you want to start that patient on an heparin, for example. You want to give them, load them with aspirin and call cardiology or not. So there are other things that we have to keep in mind when we're coming up with a plan. دكتور كريم أهلا وسهلا نرحب فيك. If you have any additions تفضل.
دكتور براء أنا مبسوط جدا that you take the initiative, especially in the internal medicine, because I didn't want students and the future residents to get confused about, because we in surgery we have a different way of presenting things. It's always like a smaller version, so I don't want them to get that that's the rule, that's the way of doing things. That's why I'm so happy that you're here teaching them the internal medicine way of doing it. And that's why people like Ahmed who's going to be very soon an intern. When we hit July, he needs to learn the right way of doing things, especially for Ahmed or any future residents. For the students interested in internal medicine, yes, you guys need to learn what like the consensus of how to do a history taking, physical exam, lab imaging, assessment, and I was enjoying the way that Dr. Bara was presenting the assessment, very short, very concise, to the point. And I raised my hand to join just to give you a way, the way I always do it. I know that here, Dr. Bara, that they have order set here, order set for things usually when we admit patients here in the US, we have an order set that you can just follow. But the way I always do it in my mind, which is I always do it with the ICU style, even for the floor patients. This means that I always go by system wise and I see what the patient's needs. But this is in my mind. And even when I present patients to my team, even if they are floor status, I present them in an ICU, but in a nutshell. For example, I start with the neuro-wise, and I say, okay, do they need pain medication? And then I start putting pain medication. I go for the cardiovascular part. Okay, resume all the home meds, or hold, for example, Xarelto, or switch to heparin drab, or do an echo, for example, or do an EKG, or trend troponin if I'm concerned about, for example, MI in my patient, in my surgical patient. And then I go for the palm and I say, oh, okay, no history of CBD, or do you have a COPD? And so it's like, and so on. So this is the only take. I would like to just teach people like how I do it. And honestly, when I did this many times, fellows attending were very impressed by this way, because when I do this very quick, it just covers everything. When I do it, and again, I don't say neuro, blah. Cardiovascular, no, I don't say this. I just say the patient needs pain medication, chemotherapy is stable, we'll need an echo for this. I go with whatever I need, but without saying this is a system. But just this is my take, but I'm really enjoying I'll be just a listener for the moment. Thank you, Dr. Bara.
Hello, Doctor. Dr. Karim, Allah يجزيك الخير. That's a very good point. What Dr. Karim is talking about is the ICU way. We call it that because every ICU will make you do this when you start your residency. They will make you write your notes in a system by system way, so that you will basically not forget anything. And there's a reason why ICU doctors do that, because ICU patients are very sick, and it could be devastating if you forget something, or if something kind of slips off or falls through the cracks. So it's very important that you not miss anything in those patients. But like Dr. Karim was saying, this is a fantastic way of making sure that you don't miss anything. Because if you go in this systematic way and you think about the patient, you think, okay, what can I do for this patient neuro-wise? What can I do for this patient pulmonary-wise? What can I do for this patient cardiac-wise, GI-wise, and musculoskeletal-wise, and all that? You go through all the systems, you're going to find that you will not forget anything, and you will always be comprehensive. And yes, it's true. I completely agree. All the attendings love it. So it's a very good point. مشكور دكتور كريم.
وانا كان عندي بس سؤال يا دكتور براء، هو بيبقى في وقت مثلا لكل حاله ان انا اعمل اكزامينيشنز لكل السيستمز، ولا انا في الحاله دي مثلا هل اعمل برضو بعمل يعني جينيتو يورينري سيستم وكده، هل برضو بقعد اعمل اكزامينيشن وكده، ولا انا بركز على الحاجات اللي هي ممكن تساعدني في الديفرنشال بس؟
In residency, I think when you start, at least in the first month, حاول try as much as you can, try to do a full physical examination. Now, when you talk about genitourinary system, for example, patients won't like that. So you have to also be cognizant of the patients. If the patient is coming with a complaint that is completely irrelevant to this, then no, don't do a genitourinary system. But Try to do a skin exam. Try to do a musculoskeletal exam. Try to do a brief neuro exam. You don't have to do a full neuro exam. And the reason why I'm telling you this is because some of your attendings will have wanted you to do this, just so that you can practice, because they feel like medical students don't have enough practice in physical examination skills, and they want you, at least in the first couple of months, to practice doing physical examination and physical examination skills as a resident also. Because when you're practicing as a student, it's a completely different thing than when you're practicing as a resident who will have decision-making skills and all that. So I would try as much as I can to do it. However, just like you said, time can be a major constraint. So sometimes you will go to work and you'll have, say, 11 patients to follow up on, and you get 5 admissions. That's a lot of work. So it is okay to be focused in your physical examination. But in your first few months, you're not going to have a workload like this, most likely. Most likely, you will have a senior working with you, and they will help you out and kind of guide you through things. So I think you will probably have time to spend more time on your physical examination, and kind of get refined with time to which systems you should focus on, and be more focused in your physical exam. Any other questions?
Yes, Dr. Bara. I would like to ask you, when do we admit a patient who is coming with a heart failure to the ICU? Like, what do I see in the patient so I decide, okay, this is not a floor patient, this is an ICU patient?
Yeah, so that's a great question, and this goes again to the vital signs. So it's going to be very dependent on the patient's presentation in terms of vital signs. So if the patient comes in hypotensive, I will certainly start thinking in my mind that this patient will probably need ICU. If the patient comes in, for example, with an oxygen saturation of 65, and you put the patient on 15 liters nasal cannula, or you put them on an unrebreather at 40% or something like that, and they're still not satting an oxygen well, that patient might need to be intubated. And you usually don't treat patients who need to be intubated on the floor. They need to be in the ICU. If the patients are hypotensive, like we said, sometimes you need to start them on intravenous pressors so that you raise their blood pressure. Sometimes the patients come in, and the reason why they have congestive heart failure exacerbation is because they have another problem that needs an ICU admission, like a massive PE, or, for example, they can have sepsis from an infection, or they can have, for example, some other process going that is driving their heart failure, and that would require them to be in ICU. So I think the decision about ICU is very, very highly dependent on the vital signs. And of course, in your residency, as you progress, you'll start to have a sense for the patients that need the ICU. You'll go in the room and you'll feel like, yeah, this patient will probably get to the ICU before you even start asking them questions. So this is going to be based on judgment, but I would say always, the most important thing about your decision to put a patient in ICU or not is going to be their vital signs.
Dr. Bara, can I add something here?
Further.
Yeah, I totally agree with Dr. Bara that the most important thing when you decide hemodynamic stability, and even when I always say to the students or the residents, whenever you get a consult on the phone, the first question you ask if the patient is hemodynamically stable. So here we talk about vital signs. Okay, so if he's stable, okay, I keep listening and continue to get the whole story. If not, I will say I keep talking over the phone while heading to see the patients while in the ICU or the floor or the ED. This is a very important point to Ahmed or any future coming interns, that when you get the consult, the first thing you ask about is the patient hemodynamically stable? And this means the vital signs. Okay. Number two, I always ask about the mental status. If they are lethargic, And if they have deterioration of, if they have an altered mental status or lethargic, again, this is another criterion we get concerned about. Third, as Dr. Bara mentioned sometime, the diagnosis itself dictates that you admit the patient to the ICU. Certain diagnoses, for example, let's say PE, but again, the PE patient, pulmonary embolism, he will present with tachycardia and respiratory distress. So again, it's a vital sign problem. But let's say a patient with a vascular surgery patient that he needs, for example, to watch his neurovascular checks, or a stroke patient, you need to do a neurovascular exam every hour. Again, this to do a Q hour or every hour exam, you cannot do this on the floor. Again, this is another criterion to admit the patient to the ICU. And I agree with, when you hit the floor and during your residency, clinical judgment is a key. And that's why you become a physician. And this is why you turn from the point of being a student and then to a resident to a physician, which is you have to count on and learn how to develop a sound clinical judgment. Thank you.
Dr. Bara, can you walk us through how and when we document the history and the physical? Should we do a paper while doing or taking the history, or we doing it afterward? Thank you.
That's a good question. It's I think largely dependent on preference, but I have an opinion about this, and I will share it because I believe it's true, and I don't believe that other people who don't do it are right. But I think you need to write things down always, 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 always. They'll teach you this as soon as you get here, and they've probably already taught you this in medical school. They say not written, not done. If it's not written, it's not done. So always write things down, because you will forget. I'm telling you, you will have in one day 3 or 4 patients with heart failure who look the same, who have the same presentation, and you will mix them up. It's going to happen. This is not something that you feel like, oh, no, I can remember my patients very well. No, you will mix patients up for sure, and you will forget things for sure. Always, always, always have things written down. Always have them written down. I can't stress this enough. Write everything down, write everything down. That is the only way that you can make sure that you're doing the right thing on the right patient at all time, and you're not missing very important information. And of course, this goes to, you taking a history, as well as you writing your notes on a computer, as well as your discussions with consultants and all of that stuff. Anything that comes up, especially during rounds when your attending is talking about your patients, always have a pen and paper, or if you prefer typing, have your laptop with you. Or sometimes I do this, sometimes if I lose my pen or something like this, I write like notes about my patients in my phone, so that I can always go back to them and remember. So there are no excuses for you not writing things down. You can always find something. If you don't have a pen and paper, you write it on your phone. If you don't have that, you can find a computer and write it down. Write things down always.
100% agree. Totally agree and 100% agree.
Is there like a pre-made sheet with يعني تبقى فيها خانات زي كل حاجة، ولا بتبقى blank paper وأنا اللي بكتب اللي أنا عايزه، ولا ما بتفرقش؟
Within all the hospitals that I've worked in, nobody ever gave us a sheet that was already made, but everybody had their own way of doing it. So I had residents who had a sheet made on their, like within their first month of residency, on a computer, and they would print hundreds of copies of this, and it would have headings, basically stuff like HPI, past medical history, family history, social history, surgical history, your typical stuff. It's very similar to what people do for the CS exam. And I've had other residents who basically have a small sheet of paper, and they kind of put their patients on it. They try to, some people would have a very small sheet of paper that basically is completely black with ink when you look at it, because they would write everything down in a very small handwriting, and it works for them. And some people will have a sheet for every patient. So it depends. It's different, I think, from between every person. I personally like to have 1 or 2 sheets that I put all my patients on. And I try to make my documentation on those sheets brief, just to remember things, and then I become a little more detailed in my note in the chart. But basically, again, it's a preference issue. I think you can find out which way you like best and use it. Any other questions?
Okay, doctor. Maybe this is more of a cardiology-based, specific question, but this patient has a blood pressure of 110/63. Do you guys do you use nitroglycerin IV, and are we going to use ACE inhibitors with monitoring of the blood pressure on this patient? Also, do you still use morphine? I just want to know what your plan would look like, or how would you use medications in that?
Great points. The patient's blood pressure, I think, is normal, but you can call it soft. This is what I usually call, blood pressure that looks like this. And that's why, for example, this patient acutely, I wouldn't start ACE inhibitors. ACE inhibitors have a good effect chronically on heart failure, but they don't have a short-term mortality benefit acutely in a patient who comes in the hospital right now. So for this guy, I would wait, I would treat him, and then think about the ACE inhibitors in the future. In terms of nitroglycerin drip, that's a very advanced question. I think advanced question for our purposes here. So I'll leave that for later, because it's going to depend on the patient and the presentation and all that kind of stuff. And then in terms of
morphine,
what was your last question? I forgot.
Morphine.
Morphine. So to be honest, you'll hear about morphine a lot in the books, but you won't see it a lot in practice. For heart failure or for anxiety or for all that kind of stuff, we use it in patients who are in palliative care or on hospice, which means basically that the patients are dying and have given up on life-prolonging treatments. But I have to say that I've almost never seen it used for anxiety or for shortness of breath.
Decreases DARM mortality and oral medication. That's why it's not so good to give. It decreases the DARM mortality, and we give oral medications, or sometimes you have to give oral medications. That's why it's not very fair to be given morphine.
Okay, I'm not sure I fully understand, but I think this is a more of an advanced question. It's going to depend very highly on your attending's preferences and what they like to do and what they don't like to do. But if your question is about this patient's blood pressure is soft and morphine can reduce the blood pressure further, then yeah, I would be very, very, very careful giving that patient any medication that might reduce their blood pressure.
Okay, so the management is going to be pretty much furosemide. That's like the main line, and that's mostly it, right?
This is how I would start with this patient, and I would get the echocardiogram and basically do further investigation to rule out acute coronary syndrome, and go from there. That's how I would approach this patient.
Yeah. Okay. Thank you, sir. Thank you very much.
No worries.
Dr. Bara, I have a question. So when can we say that this patient is having a chronic heart failure? I mean, how long should he have the symptoms so that we can say he's a chronic heart failure patient now?
I'm sure if you look at the guidelines, you'll find an exact number. But to me, I would say more than 3 months, because in patients with acute coronary syndrome, we usually wait about 3 months to check their ejection fraction, or to be more accurate, to recheck their ejection fraction in order to see if their heart failure had set in or if they have improved. So I would say any more than 3 months would probably be chronic. However, don't quote me on this. Look at the guidelines. I'm sure there are numbers there that I can't remember.
Okay, thank you so much.
Well,
Dr. Bara, I have a question to you, and if it's really something you guys do, I would like you to ask the students here and future residents this question. If you guys do this, when you use escalating and high doses of Lasix or Furosemide, is there any kind of lab or parameters you keep an eye on, especially when you give high doses of Lasix? It is a practice that you keep an eye on certain lab parameters, yes or no? And if there's yes, I would like to hear from this from our speakers here. Thank you.
Great
Potassium
question.
and
Yeah.
magnesium.
That's great. Potassium and magnesium are very important. And when you get them, you're going to get them as part of a bigger lab, which is going to be your basal metabolic panel or your comprehensive metabolic panel. And you want to look also at the kidney function. It's very important to look at the kidney function for these patients because sometimes you can diurese them and dehydrate them. And you want to avoid that as much as possible because if you continue to diurese a patient with heart failure, you can dehydrate them and cause them to have acute kidney injury. So monitoring kidney function is very important. Dr. Karim, thank you. Potassium is extremely important to look at in patients with who are being treated with Lasix, as well as magnesium because they can go down with these patients.
Yeah, thank you, Dr. Bara, because this is a very common, especially with the surgical patient, we deal with they have like a borderline heart failure, and then we have to bolus, and then we consult medicine, and then we have to use escalating dose of Lasix. So important things you have to keep an eye on is potassium. Severe hypokalemia can go to arrhythmias, and it's catastrophic. And again, worsening kidney function, the patient might end up needing dialysis and having a permanent kidney dysfunction. So, and again, sodium, patient will lose sodium as well. So if you have a baseline low sodium, the patient might have again hyponatremia, and then again you will struggle with how to correct the sodium, which is a big pain. So yeah, things to watch out when you are giving escalate. I'm not talking about small doses. I'm talking about someone who is not in heart failure, not responding, and you are using now going for escalating doses of Lasix and then switching to Lasix strip. Things to keep an eye on. Thank you, Dr. Bara.
Yeah, perfect. And especially when we talk about sodium, a lot of these patients are already on thiazide diuretics, so hydrochlorothiazide, chlorothalidone. If you do both a loop diuretic and a thiazide diuretic, your risk of getting hyponatremia becomes very high, and you absolutely need to be careful with these patients.
I like also to add that patients with heart failure can have dilutional hyponatremia due to volume overload, and actually hyponatremia itself is an indicator for death and in these patients with heart failure. So dilutional hyponatremia happens with patients with severe or advanced cases of heart failure.
Yes, absolutely. And the treatment for that is, Dr. Ahmed?
I think we'll just give saline. I think so.
So for these patients in particular, I would say diuresis, because you want to get rid of the extra water. So, and that will usually help out with their sodium levels. All right. I think we have Dr. Ahmed just joined us. Do you have any questions or any additions? Would you like to participate in any way?
No, thanks, Dr. Bara, for this lecture. Actually, I'm joined for 5 minutes ago, so I'm not know in which part you speak, but okay, I'm looking for some notification or some knowledge. It is okay for me. It is helpful for me. Thank you for that.
Good, great. It's good to have you with us. Inshallah, in the future we'll be able to have rooms and you'll be here before the end of the presentation. Dr. Ahmed Hassoun.
Thank you, doctor. Even though I'm here in this room, I'm always on and off. I think I just want to add maybe that if they have if the patient has low potassium, if we check their electrolytes and we see that they have low potassium, maybe we could combine thiazide with a spironolactone to preserve their potassium level in the blood. Correct me if I'm wrong. Thank you.
Yeah, I think that's a reasonable idea. I don't want to get too deep into these treatments because you'll see that this is very, 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 very advanced information as you start to do your residency, because different combinations of diuretics can be very complicated. And it's what you guys are doing is fantastic. It's basically that, yeah, we know which medications lower calcium, we know which potassium, and which medications can increase potassium. But still, this is a very, very, very fine art and a very fine balance. I think you will learn it by the end of your first year in residency. You will start getting more involved in these decisions. And maybe in second and third year, you will start making those decisions and kind of getting more comfortable with it. I think it's too advanced at this level. So any other questions, guys?
Dr. Bara, I have a request. If you have some time, if we are wrapping this virtual round, I have a request. I would love to hear and listen from one of the speakers who has been here since the beginning to wrap us the case for us. It's like a way. I'm a surgery resident, and I would like to hear about the patient. Let's say the patient has an abscess, and you're giving me a synopsis about the patient. So I would like someone, if they are ready and if they feel comfortable with. So at least everyone now joining us, they can know about what's going on with the patient. Thank you.
Yeah, that's a great idea. Perfect way to kind of wrap things up. Anybody wants to take a go at this?
And I think again, Dr. Bara. So when I started doing this with the surgery virtual rounds, I tell people that, hey, this is here a good opportunity to practice this. So before you head an elective or observership, you can do all the mistakes here, and we can fix everything. Or before you start residency, you want to do all the mistakes here, and it's okay. But you really don't want to do this when you start a residency or when you start an elective, because you want to impress people. So I encourage people, students, residents, to do here, even if they are doing a very bad job, it's fine. But it's a good opportunity, very good opportunity, especially when you have a GI fellow that can direct you of what.
Yeah, 100% agree. This is your time to make mistakes, guys. So let's go ahead and make some mistakes. Dr. Ahmed, you're going to start your residency soon. Let's hear what you have.
Yeah, exactly. Ahmed, you are the one that you will, in 4 months. This is you. I'm talking about you right now. Okay, I don't want to mention names. Okay. So you will start a residency in 4 months. You want to do this bad job now rather than in July. Thank you.
Okay, thank you so much. Okay, so a 65-year-old gentleman came to the emergency department with severe dyspnea. His oxygen saturation was 88%, and he was put on 4 liters oxygen on nasal cannula. His vital signs were normal except for respiratory rate, which was 33, and he was admitted to the floor. And when we took history from him, he complained of severe dyspnea. I don't know the analysis of dyspnea. I wasn't here when they did the analysis for dyspnea, and he denied nausea, fever, vomiting, or cough. And on physical examination, he had no jugular venous distension, no clubbing in his hand, and in auscultation of his lung, there was basal crepitations in his lung, and his heart auscultation was normal. There were no murmurs. And there was full beating edema in his lower limbs, and his abdominal examination was normal. His neurological examination was normal, and investigation when doing X-ray, he had pulmonary edema on chest X-ray, and and after that, the management plan was to give the patient furosemide diuresis for his volume overload and the pulmonary edema. He is already in oxygen, and we didn't use morphine here. And we can use ACE inhibitor later, and the patient was admitted to the floor, as I said before. And we required transthoracic echocardiography as the initial test to diagnose his heart failure. So the patient most probably is having a heart failure due to most probably coronary artery disease, because he had history of chest pain before, and the other differential diagnosis is COPD, pulmonary embolism, and that's it. I know it's not organized, but it's my first try, so sorry.
لا, good job, Ahmed. And I'll tell you this. I think one of the main problems, and it was my mistake, is I didn't ask everyone to write things down when we started, because this is how you're going to get prepared. So
Exactly. Writing everything down, and then you can rehearse it. Okay. Exactly. Thank you.
Okay, great.
Perfect. Yeah.
I do that next time. So.
Yeah, exactly. So next time I'll make a point of saying this in advance, that everybody here just start writing things down from the beginning, and then you'll use your notes to kind of make an organized presentation. أنا بس حاب أرحب بالدكتورة رنيم. أهلا وسهلا. I think she just joined. دكتورة رنيم, I think من الجامعة الأردنية, صح? I think.
هاي براء, كيفك؟
Yeah, تمام.
دوامنا قايني مع بعض يا زلمة.
Exactly. Yes, exactly. I think we were 1 or 2 years apart.
Yeah. I think you were 2 years ahead or so.
Yes, exactly. So welcome, Dr. Ranim. If you have any additions.
Thank you. Yeah, I'm sorry I came in after you guys had already done your discussions, but I'm happy to listen to what's left of this.
مش مشكلة. Good. Dr. Ranim, عم تعمل I think surgery residency, so it's good to I think get together with Dr. Karim Ibrahim, who's with us. I think Dr. Karim does a very similar thing for virtual clinical rounds in surgery. So you guys might help each other out in the future if you want with the surgical residency related stuff. Okay, so I think I would have to go in about 5 minutes. So if anybody else wants to add anything, let's hear it now, or otherwise it's gonna have to wait until next time. Anybody wants to say anything?
I have a question. I have a question for Dr. Ahmed about the presentation. What's the most important lab work you would like to check and tell me about when you were talking about this patient presentation? Thank you.
Transthoracic echocardiography and the EKG.
I'm saying labs.
Lab work. Okay, so lab work, we can say brain nitrotic peptide, BMB.
Thank you. That's it. Thank you.
Okay, thank you so much. Dr. Majid is here too, so I think he wants to say something. He is a hematology and oncology fellow, so.
Dr. Majid.
Thank you. And again, I'm sorry, I kind of gotten a little bit late. I don't know if this was mentioned or not, but I had a couple of things to add on. Was it discussed, like, why would you choose IV Lasix instead of PO in such a patient? And if not, maybe can someone tell us why would that be important in such a patient? And then the other thing, how often are you going to be redosing the Lasix and rechecking it?
Anybody wants to take a crack at this?
Well, I think because the patient is having a heart failure right now, so the circulation around the GI is not very well, so the absorption of a PO is not going to be good. That's just my understanding of it. I'm not sure of the
Absolutely right. Absolutely right. These patients would have a significant amount of gut edema, and therefore GI absorption is not going to be adequate.
Okay, what was the second question again? Sorry.
So you gave them a dose of Lasix. How often are you going to recheck on them? What is the methodology you're going to use to decide if you're going to give more Lasix? How often?
Oh no, I'm not sure. I'm sorry.
So you gave this patient
Maybe
the first dose of Lasix. So how are you going to decide if you're going to give a second dose or not? Or what are you going to be monitoring? And then how often are you going to be redosing the Lasix?
I think physical exam by ausculting the pulmonary auscultation would give us a help, I think.
Maybe potassium.
Generally, so I would definitely recommend the electrolytes to be monitored every time you're going to redose the Lasix.
Potassium.
You can check it definitely every time you're redosing, but in the hospital setting, you don't want to X-ray them every once in a while. You can definitely listen to the lungs, but the biggest two things that we usually monitor are the ins and outs, and then the weights, standing weights. Those are the two things that are going to guide you to how more you would want to diurese this patient.
دكتور ماجد معلش اول حاجه ايه غير الويت ما سمعتهاش بس
الins والouts. So you want to monitor the input والoutput, and you're gonna usually we aim for like a goal of negative 1 to 2 liters every day or something like that, depending on how overloaded the patient. There's not really a clear-cut guidelines. It's kind of arbitrary numbers we come up with based on the patient's the presentation of volume overload. And then you monitor these numbers, you decide like, is he there yet? Can we like get more fluids off of him or her? And then you take it. And then how often would you do that? Like the redosing? What's the interval of time? What's the effect? How long do you expect the Lasix to effect last for diuresis wise?
A day. I'm not sure, but I would say a day, 1 day.
Actually, it's in the name. That's why they call it Lasix. The effect lasts for about 6 hours. So usually we monitor it every 6 hours or so.
This is a very good tip. I'm learning. I'm a surgical resident here, and I'm learning a lot. And I like this kind of question, because those are the things that you have to know. You have to know all this kind of detail. Thank you, sir.
Thank you.
طيب يا جماعة مشكورين جميعا. مشكور دكتور ماجد for the good points, good questions. Inshallah we'll see you again in rooms like this and have better discussions in the future. I think I have to go right now. I will leave the room if you guys want to continue the discussion. But thank you all for coming. ويعطيكم العافية جميعا، موفقين جميعا. والسلام عليكم.
شكرا جزيلا.
شكرا دكتور براء.
شكرا. ان شاء الله عليكم السلام. ان شاء الله يا جماعه هنعلن برضو قبل الروم، وبرضو هنكتب التعليمات اللي هو عشان ان احنا نحضر معانا ورقه وقلم وناخد النوتس عشان نبقى بريبيرد. واتمنى الناس زي اللي شاركت النهارده تشارك اكتر المره الجايه ان شاء الله. كلنا بنتعلم وبنغلط، مفيش مشكله. هي دي الفكره من الرومز دي، نغلط دلوقتي. بس حابب تضيف حاجه احمد؟
انا برضو بقترح ان احنا في الاعلان اللي بنعمله على جروب الفيسبوك نكتب البرزنتيشن بتاع الكيس، بحيث الناس وهي داخله من جروب الفيسبوك تشوف البرزنتيشن كان ايه.
ماشي خلاص.
يعني حضرتك انت بس تستاذن من الدكتور براء تاخد منه برزنتيشن قبل الروم تكتبها فوق
العيان بيشتكي من ايه بالظبط
تكتبها فوق الايفنت هنا كمان برضه.
خلاص ماشي ان شاء الله.
تمام. ده sounds like a good idea.
تمام. شكرا جدا يا جماعه، شكرا جزيلا لحضرتك دكتور براء. شكرا يا جماعه كلكم.